So welcome. This is a webinar about family-based psychedelic therapy. My name is Ingmar Gorman. I am a psychologist and the co-founder and CEO of Fluence, a psychedelic training company. So I'd like to just start off with a little bit of an orientation. As I mentioned before, you can use the chat to let us know where you're from. Also, if you have any questions for us, we will be doing a Q&A on the end of this webinar. There's a specific Q&A button on the bottom of the Zoom app. So please use that Q&A button. That's one way that we can monitor your questions without losing them in the chat. It'll be really helpful if you submit your questions there. And just so you know, this webinar is recorded and it will be available for on demand at your own leisure. So if you have to leave early for whatever reason, or you'd like to share this with a friend, they'll be available on our website soon after. So I am very excited to be introducing Dr. Adele Lafrance today. I'll just share a little bit about her background. She's a clinical psychologist, a research scientist, and author and developer of emotion-focused treatment modalities. She is active in research and practice of psychedelic medicine and has a focus on ayahuasca, MDMA, psilocybin, and ketamine. She has a particular interest in mechanisms of modeling and models of healing, which include emotion processing, spirituality, love, and family-based psychedelic medicine. And so one of the reasons why I'm particularly excited about this conversation with Adele is particularly the focus on interpersonal relationships and family systems within the context of psychedelic medicine. And I'll say that in my training background, when it comes to psychedelics specifically, I found this to be really an area that was overlooked and neglected. Yet it seemed like every case video we watched, or later on, every participant that I had in a psychedelic clinical trial, some sort of concern or challenge or need in the participant's life in relationship to another close person in their system, in their family or close friend, that something was coming up there. And I was quite surprised that we were never really prepared for how to integrate, to bring in these close these important people in these participants' or patients' lives. And so I'm just really eager to have this conversation with Adele. Maybe without further ado, Adele, welcome.
Thank you so much. Thank you so much for having me and for your interest in this topic. It's definitely lacking, as you mentioned. And so it is a delight to be able to be here today to chat about it.
That's great. That's great. I appreciate that so much. I was thinking about a case actually, where, just to make it quite broad, we think about psychedelics. We think about sometimes the rapid healing that people can experience. And there was a particular case of a woman who had a very particular role within her family system, right? It was that she was the one that she was the identified patient. She was the ill person. And her husband's role was the caretaker, the provider. And throughout the course of this treatment, she was able to regain a sense of autonomy, a sense of power, ability to engage with the world. And as she began to shift into wanting to take on more action and in her life, that caused a problem for her husband, because that meant that he had to shift and change, and his role was going to change. So we'll get to that, but I wanted to provide a
great example because it is more common than not. It's a wonderful example.
So even when things go well, for the patient, there can be challenges. And so I just wanted to bring some color to this as we get into this conversation about psychedelics and family. But the place where I would like to start with you, Adele, is actually in a question that you probably get often, but I was going through your publication history and was just looking at sort of the different subjects that you were publishing on. And psychedelics are, relatively recent. I mean, I'm sure publications going 3-4 years back. So the curiosity, of course, is why, and how? What went you from being a well-published researcher in the area of family therapy to transition to psychedelics, or to integrate psychedelics into your work?
Yeah, no, I mean, yes, that's a good question. I was psychedelic naive. I did not even know about the early research on psychedelics in terms of their potential for healing and growth. But I was very active in clinical work, but also the development of new treatment modalities for eating disorders. And was working on the development of emotion-focused family therapy, which is now a recognized treatment model for eating disorders, but other mental health conditions. And I learned of the work of Gabor Mate, specifically using ayahuasca to support individuals with severe substance misuse. And I saw a documentary after having gone to a talk that he gave in my hometown of Sudbury, Ontario. And someone in the crowd asked him about his work with ayahuasca. I knew all of his conventional work, so to speak. I'd read all of his books, and someone's like, "Oh, can you tell us about your work with ayahuasca?" And I thought, what? What? I'd never even heard that word before. And I was curious because I'd never heard that word before after, reviewing his material. In any case, the way he responded also piqued my curiosity, because he was like, "Well, we're not really here to talk about that, but if you tune in on Tuesday of this week, you will see a documentary on the nature of things with David Suzuki, where I talk about that work." And in Canada, David Suzuki is highly respected, and that documentary is highly respected. And so I went home, set my DVR to record, and then I watched it. It's now available on YouTube for free streaming, by the way. And I thought, oh my gosh, we had just had 2 people die in our related services. One secondary to a diagnosis of anorexia nervosa. And so I don't know that kind of made me a bit more flexible in terms of considering this potential medicine. And so I emailed Gabor and just said, can you tell me more? I work in eating disorders. I work in the development of new treatment modalities, et cetera, et cetera. I didn't hear back from him, so I emailed him again. And he responded, and he invited me to attend a retreat, both as a participant, but also as a learner, in my professional role. I mean, I said yes. I think because I was also going through in vitro fertilization treatments at that time. And so really keen to do whatever I could, to support that process. In other words, I felt desperate professionally and personally, which is not necessarily the best mindset to approach psychedelic medicine, but I felt really safe knowing that he was there. And then while I was there, I witnessed, healing like I had not witnessed before in conventional medicine, conventional psychotherapy. And I came home and gathered a team of researchers, and we started publishing. So that was in 2014. And every year since, we've kind of just been fueled by the momentum, by the possibility, by the potential. But as you noted, I do have concerns with individually oriented models of psychedelic therapy because of the potential of systemic distress that you talked about, but also because we're missing out on leveraging positive outcomes by including close others. And so more recently, turning my attention to that kind of work, integrating psychedelic medicine and the family work that I had been doing, for the last 7 years before that, I guess. I'm not sure.
Yeah. Well, there's so much to comment on there. I mean, just thinking about that, the juxtaposition of that life, death, and life and birth, and all that was
Right.
happening at that time. Um, speaking of which, in a way, um, maybe I'll save this question for later. But let's dive into a little bit into EFFT. So
Sure.
people listening may not know what emotion-focused family therapy is.
Mm-hmm.
So before we dive into the psychedelic piece, could you just help clarify a little
Yeah.
bit about what the principles of that might be?
Yeah. So it was very much influenced by my work in eating disorders, which is really interesting because in the treatment of adult eating disorders, family members are involved. Many, many years ago, they used to do what's called parentectomies, and they would remove people from their families, thinking that their families caused their illness. And then we had a major wake up call, in part because of parent advocates who kind of said, like, enough is enough, stop blaming us. We actually have so much to contribute to, we can help. Yeah, we're not perfect. And we're also affected by the illness, and our relational patterns are affected by the illness. We deserve, respect, support, etc. So I came from, so I was in, really much raised in that area as a psychologist to think about recruiting, resourcing, supporting close others to support the healing and growth of the person who's struggling. And in that case, most often it was with an eating disorder. So I worked with teens primarily, but that model was being rolled out across the lifespan, including with adults. And we were taking the lead, or we were following the lead of our colleagues at the Maudsley Hospital in London, who were totally integrating parents, partners, friends, other family members in the care of the adults who are suffering, in their service. And so EFFT was developed to formalize the theoretical orientation in doing so, coupled with specific interventions, tools, techniques, so that when people are receiving care, the therapist or the clinician is not only taking care of that person, but they're also recruiting important people in their lives to resource them and to offer them support. And we kind of think about it like to help them engage in more of the good stuff and less of the not so good stuff. So we can promote, recovery focused environments. And within EFFT, we teach 3 different skills modules to parents and caregivers. One is behavioral interventions, emotional interventions, and therapeutic apologies. And so they learn specific skills in each of these modules so that in the home setting, or at least outside of the clinic, they can support the healing process, the recovery process. It's more akin to what's now being referred to as community models of care, where we equip people, lay people, with skills that we unlock as the professionals, our skills, and transfer them over so that we can offer care that is more culturally relevant, whether that's the family culture or the broader culture, etc. So that's kind of the essence of it. And then there's 2 other modules in EFFT, which I love. And they're block modules. So if a caregiver is engaged in a problematic pattern of relating to their loved one, or they are feeling resistant to engage because they're afraid that if they do, something worse might happen, or if a clinician is feeling like, oh, I'm having a hard time connecting with this client, I don't really like them, or I don't want their mom involved, or I don't really believe in recovery in this particular situation, like I'm having these little thoughts, then there's these modules to work through some of those internal reactions to get back on track with the work. So that's kind of the essence of the model.
Is that the emotion focused part? I'm curious just where the
it's a terrible name.
Or is it just sort of, is it ever just,
it's a terrible name. I wish I could rename it. It's a terrible name. It was very much influenced by emotion focused therapy in that we wanted to teach parents, caregivers, other support people, emotion processing skills, so that they could help their loved one. And then we kind of had a conceptualization of how when people are blocked, they're most often blocked by emotion, most often blocked by fear or shame. But the model is not just emotional. There's also a focus on behavior. on relationships. So yeah, if I could rename the model, I totally would.
So kind of the next thought is, well, how can psychedelics intersect with EFFT? Can they, if they do, what do you think they might change or modify in that relationship?
Well, we've had the opportunity now to integrate principles of EFFT in three research studies that have been completed and one research protocol. And it has been probably the most fun twist, of my career, to be able to kind of marry these two ways of supporting people. Should I just use an example?
Yeah, that would be wonderful.
Okay, so at the MAPS conference in Toronto earlier this year, Jennifer Danby from Imperial College and I presented on family matters in psychedelic therapy. And specifically, we introduced some preliminary data from a psilocybin trial where EFFT was integrated within the model. And every participant who went through the treatment had to identify a next of kin. That's the language that they use in the UK. But basically, a family member, a partner, an adult sibling, or a close friend. And that individual engaged in some prep work to understand the therapy, to understand the why for the therapy, the how for the therapy. And then they were also kind of given a heads up about how the engagement in this healing process might affect their relationship and how they could be supportive if their loved one came to them and shared with them insights or memories or suffering that had been uncovered, and every next of kin or close other had sessions with Jen, who was the primary therapist for the next of kin. And after each of the medicine sessions, which was really, really amazing. And so we also integrated EFFT in the context of a ketamine-assisted psychotherapy, two studies, actually. And in that study, we brought the support person into the prep session. And so they actually participated in the prep session. They heard all of the same preparatory information, which was amazing, because one of the things that we talked about in that prep session was that there might be the need to renegotiate unconscious contracts, which is how we refer to the process that you talked about in that case. And we also talked about assertion and anger in particular as a marker that things were going well. So we named it beforehand, and that made a huge difference. I remember there was a woman who brought in her sister, and they said that they had the richest conversations. They felt the closest during that research protocol than they'd ever felt, which was so amazing. And like, one of the cool things was we were talking about anger, like, oh, does your sister show anger? What's her comfort with anger? And I'm like, oh my gosh, no, that's really not something. Okay, well, we're going to want that to happen. So, if we're supporting it and it comes out, it might come out as a teeny tiny little whisper. So we want you to be aware of it, or it might come out in a really big way that is uncomfortable or stressful or distressing. And in that case, please let us know. We can support you. But either way, it is a sign of growth, of healing. So that was the kind of the one piece. And then they were invited to participate in some of the dosing sessions if the person who was receiving the ketamine wanted that. And we made sure that we asked them separate from their loved one, because what we found was that people would be like, oh, I guess so. And that's, not something that we would feel good about. So we're like, okay, we need to ask separate. We need to pay attention to the language used so that it's not like, oh, if you think that could be a good idea, it's like, no, let's check out. If it's not a yes, then it's a no for now. But some people did bring in their support people, either for the pre-ketamine prep the actual ketamine experience, the debrief, or all three. And at the end, the family member was also invited to be part of the closing session, either the full amount of time or half. Again, always dependent on the person receiving care. All the while their loved one was going through this ketamine protocol, the support person also watched a video very similar to the Imperial College one, and they met twice for 90 minutes with an EFFD therapist who taught them emotional support skills, emotion coaching skills, and helped them to navigate challenges that they were experiencing in the face of their loved one's kind of transformation. So those are kind of some examples of how the two can be married, but I guess it would be to minimize systemic distress, because healing does affect systems, and because this kind of healing tends to be more rapid, then the impact on the system can actually be more problematic, but also to optimize outcomes. Because if you're feeling sad and your therapist validates your sadness, it'll feel good. But if your mom validates your sadness, or your partner validates your sadness, even if they don't do it as perfectly as the therapist, it'll have much more of an impact. And we see that all the time with the therapeutic apologies module. Like, sometimes those experiences are psychedelic in terms of their impact. So it's to minimize harm, but also to optimize outcomes.
Right. Yeah, well, thank you for sharing all that that detail. It really brings it to life. I was reflecting on some of my own experiences in clinical trials, and there really isn't. If a study is specifically designed to integrate this element, then of course it can include family members or identified individuals, but sometimes clinical trials aren't designed with this in mind at all. And then you run into issues around, well, can we, is it deviation? Do we have the consent of the, do we need to consent the loved one to be able to participate in the study? I do think or reflect on some of the times that we've brought in a close personal person of the participant. And we learned quite quickly also the point that you made around bringing somebody into the preparation session, that when we missed that and realized maybe after the first dosing session that we really need to bring in a particular person from the participant's family, then it's a much more difficult to catch the person up.
Right.
Right. Like the participant is in a different emotional place. Their loved one is a little bit confused about what's going on, and they haven't received that information, that preparatory information about, well, these are things that might happen. These are things we might anticipate. And so it's just clearly such good practice. And I really appreciate your point around, not just sort of minimizing risk, but really optimizing the outcomes and the benefits, because you're right. What you sometimes do observe in psychedelic therapy is a very, very close attachment that forms between the patient or participant and the therapist.
Yeah.
And that is made use of, and I think is part of the healing process. But also we as the therapists, particularly in a clinical trial context, cannot be available to the person as much as they definitely want and need. And so having another person in their life that is involved with them maybe on a daily basis, I could, the therapeutic apologies is just another level to that. But just having that person is so important for I think a smooth process in the treatment.
You make two really good points there, because it's like, on the one hand, you might even think about, like, in the situation that you just described, where therapists aren't available to provide the care that we know is needed in some cases, it becomes an ethical imperative to resource their system. The other side of that coin, which has been another ethical kind of question of mine, is the process of consent. There's this concept in the psychotherapy literature, and in particular the marital therapy literature. It's called iatrogenic divorce. So therapy or therapist-induced divorce, where there has not been sufficient care towards a system when only one person in the system is receiving care. If we knowingly engage an individual in psychedelic therapy who is partnered, and we don't tend to the potential issues, then there is a chance that we're engaging in a process that could lead to harm to the partner. And so I don't need my partner's consent to decide to go to Peru and go on an ayahuasca retreat. But it would be really, really, really wise, important, respectful, caring, loving to talk about the timing of it, because when I come home, I might be really under-resourced temporarily. I might be very unintegrated. I might have all kinds of ideas about how I would like to change my life to live in better alignment. And that's all going to have an impact on my partner. And so, okay, they don't get to consent to my healing choices, but is there a gray zone there, a gray area that we as clinicians can shine a light on, so that we can support the system, even if we never get to meet the other people in that system.
Yeah, I think that's a really great metaphor of shining the light into that gray area or into that that darkness. Often this comes up in my mind as it comes to the countertransference of the therapist. So, if I'm in a one-on-one therapeutic relationship with a patient and they're going through some dramatic shifts in terms of, their inner healing, what, as you mentioned, sort of that sense of what is a good life lived for them, what are the changes that they need to make. I, as the therapist, can be really bought into this, the narrative, that growth process, and I can be quite convinced that yes, this person needs to get a divorce, right, or what have you, or dramatic shift. And I think that is again one of these, they're the kind of almost like there's an attraction to this. Oh, the psychedelics are working. They're going to be making a big decision in their life, and as you said, this could be an iatrogenic kind of harm if we aren't really paying attention to bringing in the other family members or a larger picture of what's happening here.
Yeah. Like, I really believe very strongly that anyone who's engaging in psychedelic therapy with adolescents in particular need training in systems and in family systems specifically, because I've observed, not always, but sometimes, that people who have unresolved, unhealed wounds with their primary caregivers can end up influencing the care that they deliver to adolescents, specifically related to separation and individuation processes that can be really delicate when, they're delicate, period. Most of us have struggled to get through them. And then again, you add in these powerful medicines. I just would hope that that there is an eye to specific training on how to navigate those specific processes. And when people say to me like, oh, I feel like she really needs to be like away from the parent, and I'm not talking about situations of active abuse, or reportable neglect. But one of my mentors said to me once, when I was advocating to do individual therapy with a teen, he said, well, is your individual therapy going to make that teen feel closer to her parents or further away? If the former, you have my full support. If the latter, go back to do some self-supervision and see what's up. And that was jarring. But that was one of the greatest gifts that I received from a clinical mentor, because I started to get clarity on my rescue pattern, my rescue impulse. And that rescue impulse tended to be strongest with teenagers. And so, I mean, thankfully, I'm on the other side of that. So now when I hold healing for teenagers, I am definitely wanting to hold their pain, especially including their pain vis-a-vis issues that have occurred with a primary caregiver. But I'm also holding their parents' pain and their parents' intentions and their parents' heart, and understanding the broader context of, how they got here. It didn't start with them. I want to look at the last 3 generations of that family system and what happened to them, what cultural, historical, political, religious forces messed with their family, so that it's not just a like, oh, mom has to stop criticizing or dad's not engaged enough. It's like, no, I have a portal of entry here, which is the adolescent, but my goal is to bring healing to the system through that portal of entry. If that makes sense.
Yeah, absolutely. Well, maybe that would be a good entryway, no pun intended, into something that you and I discussed before, but I'm sure our audience would be really interested in. So you've talked about this tripartite model of family therapy within the context of psychedelic medicine. Mm-hmm. Can you say a little bit more about that?
Yeah. So when I was trying to kind of put my ideas or organize my ideas, let's say, sometimes I get lost in the caverns of my mind. I was thinking about 3 different models of family based or family oriented psychotherapy or psychedelic therapy rather. And so the first model I call family supported psychedelic therapy for healing and growth. Family supported. So that's the models that I talked about with the ketamine, with the Imperial College study, where we recruit close others, we offer them skills, resources, support to minimize systemic distress, optimize outcomes. So that's the first model. The second model is family-based psychedelic healing and growth. So not family-supported, family-based, where family members are doing medicine work together. And so we have done that with ketamine, with ayahuasca, where with lots of prep work, lots of support, we engage members of the same family, biological or chosen, by the way. We use the word family very broadly. And then they engage in medicine work concurrently together. I shouldn't say not concurrently, not side by side, together, although it can be concurrently, as in like in different rooms or on different nights. Anne Wagner in Toronto is going to be leading one of the first studies where a couple will be dosed, both of them will be dosed together, which is going to be so amazing in terms of what we can learn, about the potential of that model. And then the third model, I guess is a bit more novel. It's the one that I am so fascinated by in terms of the mechanisms of action. But the third model is what I refer to as surrogate healing. And that's when an individual is really suffering, either with a mental health issue or a physical health issue. And for whatever reason, they're unable to participate in psychedelic medicine or psychedelic therapy. Like maybe there are contraindications in terms of their medical status, or they're on an SSRI, or there are psychological contraindications. And so a close other engages in psychedelic therapy, at least in part, on their behalf. So I interviewed a mom and a daughter. The daughter was not medically stable enough to engage in medicine, but was in need of help ASAP, potentially life-threatening condition. And so mom said, you know what, I'm going to go. Because daughter tried to get into the retreat, but was denied because of her medical status. And so mom was like, I'm going to go. And I happened to be at this retreat. And so I witnessed it. It was incredible. And every medicine experience, mom was like, show me what I need to know about my daughter. How can I help her? What can I do? And it was so beautiful. And there were things that were happening that I can't yet explain, especially using conventional scientific vocabulary. But suffice to say, by the next year, the daughter was medically stable enough because of the support that mom had provided to her, informed by the medicine. This mom had been to several treatment programs. In fact, she'd even done EFFT. None of it was enough. And daughter ended up attending a retreat and had a profound experience. And then they ended up doing medicine together. So they went from surrogate healing to family-based, psychedelic medicine, which is so cool. And it's a good story. It has a happy ending. Of course, not all like that, but the surrogate healing model, I think, is really cool, but also complex because there are all kinds of ethical issues to consider. And the people holding that space need a specific set of skills, etc. But those are the three models: family supported, family based, and then surrogate.
That's fascinating. So I imagine that our audience will have a lot of questions about the final one in particular. And I'm tempted to dive in, but I think I would be amiss if we don't give an opportunity for maybe our audience to see some of the clips that you have that are kind of connected or related to some of these models. Would you mind sharing some a video with us that might be illustrative of some of the ideas that you've shared with us?
Yeah, so I talked a lot about family supported. So I'll show you a video of a couple who engaged in family-based psychedelic medicine. And I guess the setup is that in the couple, the man who you'll see in the video had a history of treatment-resistant depression. So tried so many different healing modalities, including different combinations of medications for severe depression. And it wasn't working. And he wanted more, she wanted more for him, she wanted more for them, because of course it had an impact on the marriage, on the parenting. And so they decided to engage in this mode of treatment. But the other thing I just want to add about this clip in particular is he talks about some of the mechanisms of change of having engaged in medicine work together with his partner. Many people who have treatment-resistant depression also have deep self-loathing. They're really lacking in their capacities for self-compassion and for self-love, despite the mantra repetition, despite the worksheets, despite, all of our best efforts to help them connect with their essence. And so I just wanted to highlight that for people who watch this video.
I think two things happen very distinctly, although they happen almost in kind of slow motion with the psychedelic medication experience together, which is that I look at Mindy and I see someone I love, right? I mean, that's just unquestionable. And the psychedelic medication just really helps kind of move away any of yesterday's kind of hurt or the day before's hurts, or, metaphorically speaking, the past's hurt. The second really, I think, profound thing that happens is I see the love that Mindy then has for me. And I'm able to internalize that for myself as this, wow, if Mindy sees me this way, I should pay attention to this person who is me, right? I mean, if she sees me this way and I can see that in her eyes through this psychedelic medication, then I should pay attention to this human being that she's looking at, which is me. And then I get to have kind of that like reciprocate, and that just is a cycle that it's like a really good wash cycle. Like it just keeps going back and forth between the two of us, and it almost seems kind of like never ending, like limitless, of that kind of exchange of like reflection back and projection and all that, just kind of, it's happening.
Yeah, I would agree.
Awesome. They're adorable. And, we're about a year and 3 months out from this, and he's never had to go back on medication, which is mind-boggling. And so when I was working on the Love Project, which is another research project that I'm really passionate about looking at the role of love and healing, I asked Bruce and Marcela of MDMA training fame in Boulder to kind of talk about the role of love in their work. And they had different ways of articulating it, but both talked about how that was one of the primary healing modalities in their delivery of care when supporting patients in MDMA sessions. And I was part of the healthy control study, and I got to be a participant with Bruce and Marcella. And I can tell you, they got a lot of love to give, and that love is beautiful and pure and extremely healing. And also, if love is a primary agent in healing, and Carl Rogers talked about unconditional positive regard. I mean, he was really talking about love. It was just way too risky to use the L word at that time for lots of good reasons. Then imagine leveraging the love of someone with whom we've already engaged in a process of oxytocin-based bonding, you know? And of course, that doesn't mean everyone's going to be able to participate, because there are some personality dynamics or relational dynamics that risk, arising that the clinician might struggle to hold. But wow, the potential there is so incredible. And Women's Health magazine did a little interview about my family, because we engaged in psychedelic medicine together. And some of my most precious memories of my life are moments where, my dad and I were deeply connected, or my mom and I were deeply connected, and sometimes without having to say a word. And so, again, it's not just about minimizing distress, but optimizing outcomes. And when I use the words optimizing outcomes, honestly, it seems so like empty, flat. Because what's possible here is something that can be described in a much more intense way than optimizing outcomes.
Well, I'd love to stay with that this topic for a moment, but it's just a little digression. I remember when I was in training as a psychologist, one of my supervisors was Dr. Phil Lister, who's now one of the lead educator for MAPS. And he asked me this question. I was seeing a young adult, and she and Dr. Lister asked me if essentially if I had love for her. And that was the first time that anybody used the L word.
Whoa.
In relationship to a patient, and it was shocking, and it was shocking in the sense that it changed the way that I conceptualize the therapeutic relationship as an element or ingredient within the therapeutic relationship. But I think it also helped me get over that shock, get over that almost stigma around that word when it comes to how we do psychotherapeutic work.
For sure. I mean, there's reasons to be afraid of that work in psychotherapeutic work, because many people have hurt vulnerable persons under the guise, of love. And so what we're talking about here is more akin to unconditional positive regard, but we can now hopefully, use the L word more frequently. Yeah. So that's really cool.
So getting back on track, you spoke about you touched on a few things. One, sort of the limitation of language a little bit. You touched on sort of the restrictive aspect of science, although, as both of us, I know we are very firm on the importance of evidence in science.
Sure.
There's no question about that. So I guess here's my one question I've been kind of burning to ask you, which is, you developed, well, no, okay. Sorry, I'll put this a different way. When you listen to those, that patient on that video recording, and he was using this language to describe his experience, right? This almost this cyclical nature of it, and him seeing himself through her eyes. I guess the question is, in a way, like, it would be foolish to try to reduce that down to a mechanism of action. But I
I
think
figured
that's
it out.
okay. All right, you have. So that is my question. Like, how do we, just to say it, like, how do we take, we can use measures and standard tools and all that stuff, but when you have such a diverse expression of and process of healing through psychedelics, how can we help narrow that down? Because just like EFFT is focused on family, maybe focused on emotions, behavior, like we cut it up, right? That's not how we live our lives. So I'm just curious, how do you think about that?
Okay, so this is by no means complete in terms of like conceptualization of a mechanism. And I don't know how to measure this, but I interviewed someone for the Love Project, and it was a woman who had a long, long history of serious mental health issues, including lots of self-harm behaviors. And when I asked her about the role of love in her healing, she talked about like when she saw the love in the eyes of the therapist towards her, a relative stranger. At first, she was super confused by it, weirded out by it, didn't trust it. And then finally was just like, oh, no, this is real. She said, when I felt their love, I felt like I was worth something. And so I thought, okay, I think that the love we show, the ethical, professional, love that we show our clients, our patients, those we serve, the effort that we make, even when it doesn't go well, but, our effort to kind of show up and keep showing up and repair injuries, when they occur. I think that those expressions of care, love, whatever you want to call them, end up becoming metabolized into worthiness. And how that chemical process occurs, I believe, is an activation of the co-regulation to develop self-regulation system, the oxytocin processes. I don't really know. Neuroscience was never my strength, but I do believe that there is a process of metabolizing other people's love in those spaces under the effect of this consciousness altering substance that allows us to kind of note it and even pay attention to it for periods of time, integrate it so that becomes worthiness. And if someone feels worthy, they feel worthy of continued help. They feel worthy enough to say what's on their mind. They do not engage in self-harm behaviors as often. They have much higher standards for how people treat them. And so in a way, like, I think that it might be one of the core mechanisms of action that the love we show, whether it's the clinician or the family member or whatever, supports the metabolization of worthiness in the other, or self-love in the other, if you want to call it that too. I don't know. What do you think?
Well, I really, I would definitely sign my name under that. I think that what it brings up for me is this tension or challenge around the accessibility of these treatments. It's a common conversation around cost and who is the therapist, who's the provider, or is it a sitter, is it a facilitator, is it a nurse? And when it's a real dilemma, right? Because we want to reduce costs. On the other hand, it does seem, when we begin to think about reducing the facilitator to just sort of a presence that makes sure that the person on the psychedelic is like safe, right? Then it really is a focus on this sort of intrapsychic transpersonal process, that it's just the person, it's being in contact with something spiritual, it's being in contact with something that's internal, self-transcendence or something, but it misses this relational component. And I think that that's an important ingredient. And I think we could, I'd love to continue to speak with you and just geek out for another few hours, but I want to make sure that we can also get to some of the questions of our audience, because I'm sure that, they have great questions and they've been listening. So one question here that I'll pull from the Q&A, let's see here. So this is an important question. And a big one. how does stigma show up in psychedelic family therapy? And when it does, how do you work with it? How do you address it?
Yeah, I'm actually going to be doing a talk on something similar to this in a couple of months. Since I'm working on it, I'm very much thinking about it. And how we conceptualize relational difficulties, the big picture and the little picture, I guess, if you want to say that, can increase or decrease stigma, the experience of stigma. I have a couple of examples. Let me talk about the concept of attachment. When we are guided by the theory of attachment in our work, we have the risk of perpetuating a system of oppression. And attachment theory, in my opinion, the way it's been written about over the last 75 years is highly problematic. It centers so much on the mom and what she's doing or not doing and how important her role is, and especially during these years or months of life. It doesn't talk about who's attaching to her to fuel her as a life giver. It doesn't talk about who's helping her to remain attached to the land where she comes from, or to her spirituality, or to nature. It's very reductionistic. And I'm doing some work right now, learning from a liberation psychologist, anti-oppression. And it's been such an awakening for me, because I'm like, oh my gosh, we not only can harm people by what we say, but we can harm people by what we don't say. So if we don't contextualize the problems in the family within that broader context, then we're perpetuating stigma, for sure. So that's one example. Well, I'm just aware of the time, so maybe that's the example that I'll provide for now.
Well, so the challenge is that we have some really wonderful questions, and they'll take a long time to answer. So I'm gonna pull another one, and maybe this is something just for you to respond to or to think about, because I don't think you would be able to answer it. But the question is, what is the integration process for each of the three models you mentioned? So that would be the supported, the family-based, and then the surrogate. So that's a huge question to ask
Huge
for.
question.
But maybe a way to shorten it would be, could you think of any differences in integration process between those three different models?
Well, we were very much guided by EFFD theory and interventions. And so that's the one piece I would say. But what's common to all three, potentially, is the need to privilege psychological safety over joint work. And practically speaking, how we were thinking about that in terms of like the development of protocols, for example, is that there would be an individual integration session for the person who is doing the medicine on their own. And then there could be a second individual integration session followed by a third where there's a joint. But the joint one could be second, and then there's the third one that is available if needed, individually. But I guess the point that I'm trying to make in not a very eloquent way is that we are thinking that creating individual spaces for both parties, as well as joint spaces, is going to be important, but that the joint work only happens if there's sufficient psychological safety. So even the caregiver would have their own private integration session. So yeah, that's what's coming to mind.
So I wonder if because when I think about, it's terrible to say, if I think about sort of the worst case scenario in, say, a family-based psychedelic intervention, it would be one where things are coming up spontaneously, because that's what psychedelics partly do, is they kind of bring up things that you're slightly aware of, you're not fully aware, or what have you. And it can be quite restrictive if a person is not in that prepared, not just through psychedelic preparation, but just from a family systems perspective, to be able to, be in a room having this very intimate experience with a family member that they might not feel fully safe with. Even if, not even talking about abuse or anything like that, but just
No,
sort of
I understand.
a typical
Yeah.
family kind of dynamic. And so I think what you're managing is, allowing for, if there is going to be an experience where people have the psychedelics together, they're in a place where they're ready to do that. And then if something arises in the experience, they can sort of process it separately if they have to. And then, of course, perhaps optimally, it would be something that they would be able to, again, integrate together. But there sort of needs to be a little bit of a check before you sort of dive right into all of those sort of processes happening on the fly as a result of the experience.
And in those models, there's not even a consideration of just one facilitator. There needs to be 2, if not 3, facilitators in the space. And some people are like, that'll be so expensive. You know what's expensive? Is continuing to focus on this individual model of healing. That's expensive. And so, I think that I think it'll be worth it if we can convince the powers that be to allow us to spend the time brainstorming these amazing questions, these super thoughtful questions to figure out like the best how. And just so everyone knows, like, no one's an expert at this. I am not an expert at this. Like, I'm a beginner and, we are trying things and talking about it and being guided by the literature and by science, of course, but also by indigenous traditions, indigenous wisdom. And so we have a long way to go before any of this conversation becomes concrete, or final or official or best practice guidelines. I think it's a little too early for that.
Well, I really want to extend my appreciation to you. This has been a wonderful conversation. I really wish we could have it continue. Maybe we'll have to have a part 2. But before we go, I would like to make just a few plugs for Fluence as well as for you, Adele. So first, for us, we just launched our psychedelic therapy and integration certificate, which is our foundational certificate. We really encourage you to check that out if you haven't. And then very excitingly, last week we announced our collaboration with MAPS. And so we are offering MAPS's MDMA education program.
Which is excellent, by the way. I've done it. And so I really encourage people to sign up for this particular one.
Thank you. Appreciate that. Yeah, we have all of the case videos, everything from the trial. So it's an incredibly rich learning experience. And then finally, if you would like to come to one more webinar coming up next month, we have a webinar on postpartum depression and psychedelics. So another, very important topic. But Adele, I'd love to also end on the note. I know that you also have a training. I love the name of it, right? Is it Family Matters?
Yeah, well, the one that's coming up is a 2-day training on psychedelic therapy for eating disorders, which we will be talking about the formalization of the family piece. So that's the only one that I have on the books currently. But thank you,
great.
though, for bringing attention to that.
Happy to. All right. Again, thank you for your time. Thank you for listening.
And yeah, thanks everybody. Month. Thanks, Ingmar. Thanks, Fluence.
You're welcome. Bye-bye.